Hello and welcome to 2-Minute MRCP. Today we'll discuss acute interstitial nephritis, commonly known as AIN, an important cause of acute kidney injury and a favorite topic in the MRCP exam. Acute interstitial nephritis accounts for approximately 25% of all drug-induced acute kidney injuries. It is an immune-mediated inflammation affecting the renal interstitium and tubules. Let's start with the causes. The most common cause is drugs, particularly antibiotics. The important drugs to remember are penicillin, rifampicin, non-steroidal anti-inflammatory drugs, or NSAIDs, allopurinol, furosemide, and proton pump inhibitors, commonly called PPIs. Besides drugs, several systemic diseases can also cause acute interstitial nephritis, including systemic lupus erythematosus, or SLE, sarcoidosis, and Sjogren's syndrome. Certain infections are also associated with AIN, particularly hantavirus and staphylococcal infections. Now let's understand the pathophysiology. On histology, the hallmark finding is marked interstitial edema along with an inflammatory infiltrate within the connective tissue between the renal tubules. This inflammation damages the tubules and leads to impaired kidney function. Next, let's look at the clinical features. The classic presentation is the triad of fever, skin rash, and arthralgia, meaning joint pain. However, remember that not every patient presents with all three features. Patients may also develop eosinophilia, reflecting the allergic or hypersensitivity nature of the disease. Renal impairment is usually mild, although severe acute kidney injury can occur if diagnosis is delayed. Some patients also develop hypertension. Now let's discuss the investigations. Urinalysis commonly shows sterile puria, meaning white blood cells are present in the urine without bacterial growth on culture. Another characteristic finding is white cell casts, which strongly suggest inflammation within the kidney rather than infection limited to the lower urinary tract. Depending on the severity, blood tests will show a rise in serum creatinine, indicating acute kidney injury. Peripheral blood may also demonstrate eosinophilia. Now let's discuss an important condition associated with AIN called tubulointerstitial nephritis with uveitis, or TINU syndrome. TINU syndrome usually affects young females. Patients commonly present with fever, weight loss, and painful red eyes due to uveitis. Urinalysis typically shows leukocytes and proteinuria. The acute kidney injury results from tubulointerstitial nephritis. The good news is that most patients respond very well to corticosteroid therapy, especially when diagnosed early. Finally, here are the key MRCP take-home points. Remember that drugs are the most common cause of acute interstitial nephritis, especially antibiotics, NSAIDs, allopurinol, furosemide, and proton pump inhibitors. Think of AIN in any patient who develops acute kidney injury after starting a new medication, particularly if they also have fever, rash, arthralgia, or eosinophilia. Look for sterile puria and white cell casts on urinalysis. And don't forget TINU syndrome, a condition seen mainly in young females, combining tubulointerstitial nephritis with uveitis, and usually responding well to steroids. Thanks for watching 2-Minute MRCP. If you found this helpful, don't forget to like, share, and subscribe to 2-Minute MRCP for more quick revision videos.